Hello, my name is Shad Reis. I'm from MidStar Washington Hospital Center. Today is CVI 2017, day one, and with me is Mohamad Kabach. He's from University of Miami, JFK Medical Center. He's presenting to us a case about successful coronary protection during TAVI in heavily calcified AS. Go ahead, Mohamad.
Thank you for having me. Thank you for the opportunity. I'll go ahead and start. So the learning objectives of this case is to talk about the different methods of identifying patient at risk of left main compromise, to know what the indications to protect the left main during TAVI, touch base a little bit on the methods of left main protection. So we had this unfortunate case that ended up well, an 86-year-old woman. She had a known CAD, previous LED stent. She has some renal failure, and she has a pacemaker with additional history of hypertension and diabetes. She came in with progressive shortness of breath. She had some exertional dizziness and chest discomfort. On exam, she was in some heart failure signs. She had an AS murmur, and she had a creatinine of 1.5 at baseline. So she was admitted with diagnosis of acutely decompensated heart failure, treated with diuresis. She felt better initially, but she still complained of exertional dizziness and syncope. This is her baseline EKG. She had a known old left bundle with no new changes. She underwent a 2D echo, which showed severe aortic stenosis with a max velocity of 5 meters and an elevated mean gradient above 60 millimeter per mercury. So we went ahead and cath her. She had a known instant restenosis of her LAD. She had a proximal to mid 60% stenosis with a negative hemodynamics. In addition, she had a known left circ disease. So she had a proximal ostial bifurcation disease in addition to distal left circ 90%, which felt that to be old and chronic, not giving her much symptoms. Her right was tight. She had a proximal stenosis at 90% and additional 80% at the mid segment. So we decided to kind of treat the right at that point and see how she does, but she was still symptomatic quite a bit, likely from the aortic stenosis. So we fixed the right in the same setting. Then she underwent cardiac CT, part of her evaluation for TAVR, and surprisingly, she came with only 0.8 centimeter coronary ostial height with significant bulky calcified left aortic leaflet, giving her short left main with significant calcification of her left aortic leaflet. We've decided to do her TAVR with left main protection in case she would occlude her left main ostium or her distal vessels. So she went ahead and pushed 2 wires at her LAD and left circ system, and we started ballooning, and you can see the significant calcium bulk that jumped into the left main at that time. She still has some flow in the coronary arteries, but from her aortic pressure, she started to deteriorate, and we almost lost her at some point. So for that reason, we felt that we kind of have to do something very quickly. So we put 2 deflated Bermuda stents in kissing fashion, ready to go at the proximal segment. And then we implanted her 23 millimeter Edwards Sapien 3 valve, and to see how she does. And she did okay. We know that the calcium from the balloon valvuloplasty already kind of moved a little bit. So after the valve, she did have some blood pressure still. And then we decided to not leave her alone, but we decided to implant both stents to make sure that she has excellent flow. So this is her picture post valve implantation, and blood pressure went up. She was doing great, and that was it. So the reason we present this case is because despite that it's rare, we felt that coronary obstruction is a very life-threatening complication. So it's less than 1%. However, patient who has it, almost half of them would die at 30 days.
Well, can I ask you why you picked S3 compared to Evolut R?
There was no specific preference. We just felt that this is what we are comfortable with. We do it very high volume, where I came from, and
because usually self-expand or usually gentle on the calcification. So usually it expands slower, or especially when you have bulky calcium. When you are doing balloon expansion, usually you are more aggressively doing But again, this is probably, again, based on the experience. The second question I have, what is the percentage you were doing BAV prior to the valve implantation?
So we do it very heavily, actually. We most of our cases, we bring them down. We balloon them first, and then we put the valve. But there is a lot of talk about when to protect, and there are three common conditions: valve in valve, short falsafah, short sinus falsafah, and low coronary ostium.
Interesting case. I mean, it's a good call. You put the wires in, but this represent kind of planning, heart team approach, CT review before the case being on the table. And then I would like to thank Mohamad for his time. It is an interesting case. Watch this video and others on CVI YouTube channel. This is Shadi Reyes from Washington, D.C.